thank you to everybody who's come along this morning. So we've got Dr. Raelia here with us this morning, and she's a CREI Fertility Specialist. So did you just want to talk a little bit about yourself first, please?
Sure. Okay, so look, I'm a fertility specialist, and CREI stands for Certification in Reproductive Endocrinology and Infertility. What that means is that after I finished training as an obstetrician gynaecologist, which was 6 years of specialty training, I did subspecialty training for a further 3 years just in the field of reproductive surgery, endocrinology, and the study of male and female infertility, so andrology, and also female reproductive endocrinology, which is the study of hormones. And I did a lot of training in IVF, so both at the Royal Women's Hospital in Melbourne and Melbourne IVF, and also at IVF Australia in Sydney. So I've done quite a lot of extensive training in IVF, and subsequent to that, I've been in private practice and also in public practice at the Women's Hospital in Melbourne for the last 6 years. So that's kind of me. I also did a PhD in reproductive genetics. I did that before I finished my training, and that was a bit of a sidestep for me, just an interest area and a passion of mine. And one of my particular interests in IVF is to help couples who have genetic risks. So they carry a disease-causing mutational problem in their chromosomes, and we want to make sure that they can have a healthy family. So that's another niche area of my practice. But I'm also very passionate about all aspects of reproductive care, and I have a very broad practice, and I look after a lot of women with endometriosis. I do a lot of surgery for endometriosis. So that's me in a nutshell.
You're a real champion for your patients, and wow, just a little PhD on the side as a side thing. Like it's nothing big. That's a huge accomplishment. So
thank you.
Yeah, you really do know what you're talking about. So yeah, some of the questions that we've had come through, and Alicia, I can see you're there. So if you do have any questions, feel free to pop in and ask Dr. Raelia as well. But just with regarding COVID, maybe to start, is there any required testing that will need to be done before couples can resume a new cycle, just with the situation that's unfolding at the moment?
Yeah, there is. So I can really only speak from experience locally in Melbourne at Melbourne IVF, which is where I practice. But our team is actually going to test every patient. And we also, in addition to that, we're doing quite a lot of intensive screening by questionnaire. So unfortunately, we won't be able to treat anyone who has a respiratory illness, even if it's not covered, because we don't know what it is. And we're asking patients who have any kind of respiratory illness, but who do need to have IVF treatment, to be tested and to await symptom resolution before we can proceed if they're COVID negative. We're also looking into screening, and this will happen with every patient in cycle, at random asymptomatic patients, and we're just getting confirmation, but we've had initial confirmation that it will be Medicare covered. And the reason for that is that it would be a catastrophe for us, and we'd really have to pull up stops and stop treatment for everyone if we had COVID in our lab. So we're really going above and beyond to make sure that we really do everything we can to make sure that before a patient comes in for an egg collection, we've done absolutely everything to make sure they're not an asymptomatic carrier. This disease really poses a big problem for us as medical professionals, because while it can be something that causes really severe problems and respiratory illness and needing to be admitted to intensive care for some patients, it's an illness of paradox, because other patients might be completely symptom-free and asymptomatic carriers that can pass COVID to each other and to other people. So it's a really tricky one. Well, unless the government decided to screen absolutely everyone, we're not going to really know who's an asymptomatic carrier and who isn't unless we test.
Yeah, there's been a lot of talk around that. There could be people walking around that haven't been tested that might have it just because of the restrictions around testing, and obviously they have to do it on needs basis and whatnot. But yeah, that's a definite issue for sure.
Yeah, and I think at the beginning, I mean, it's a situation that is continuously changing. At the beginning, from the pathology perspective, we weren't expecting this pandemic, so nobody was. And so we didn't have high volumes of the kind of swabs to do the test that's needed. And in fact, we didn't have the test for this virus because it didn't exist. So,
Yeah.
you know, at the beginning, we were really chasing our tails. And the reason that testing was so restricted was that people were worried about running out of the actual swabs to do the test. And they were being imported from Italy.
Yeah.
So it was a big kind of barrier to testing everyone. Subsequently, you know, the whole world has got on board with increasing our capacity to test, and tests have been validated locally. So everywhere's different. In Australia, there's different pathology companies, but for example, I can tell you that a weekend ago, I had a sore throat, and because I'm a doctor, even though I was not thinking I had COVID, I thought I probably just had a cold. But because I'm a doctor, I shut my practice for a couple of days.
Yeah.
Luckily, it happened kind of on a weekend. So I went into a staff clinic that's been set up at a hospital where I operate called Epworth in Melbourne. And I actually have to say, I was so impressed with the process. They really have streamlined it. I was the only person in the clinic at the time, so there's real social distancing. The nurses were really well protected. And they did a swab for me. They took swabs of my tonsils and they stuck a horrible thing up my nose, which only lasted a second. It wasn't too bad. And then I waited for the results and then waited 48 hours after I was symptom-free before resuming my practice. And it wasn't COVID, but if it had been and I had gone to work, that would have been the wrong thing. So I think every time we get a cough or a cold or a sneeze, as a health professional, we're going to be tested. And every time a patient has those symptoms, even though 99.9% of the time it's not going to be COVID, they are going to be asked to not undertake treatment because of, you know, the possibility that it's COVID and the possibility of passing it on, and they'll be tested.
Yeah, it's sort of like that herd immunity almost, like you're doing it to protect others as well as yourself.
Yeah.
Yeah. No. I guess from there, with testing resuming, a lot of people might have frozen transfers that have occurred. One of the questions that we had sent in was fresh or frozen transfers. From your experience, which get better results?
So again, the word paradox keeps coming up because I think the answer to that question is a paradox. So what I would say is, let's think of it from the point of view of the embryo, and let's think of it from the point of view of the womb and the lining of the womb, the endometrium. And, you know, the perfect scenario is a fresh embryo in a natural endometrium. We only get that in two contexts. We get that in a donor cycle, so when the embryo is fresh but the lining is more natural, or we can get that in a egg thaw cycle. So for someone who's frozen eggs in the past, and we take them out of the freezer and fertilize them, so the embryo is kind of fresh, even though the lining is not influenced by the stimulated hormones in that particular cycle, so the lining is natural. That would be, sorry, I know I might get a tissue in a second.
Yeah,
that's the best of both worlds. What's best for the embryo is often not what's best for the endometrium, and we have to make a decision based on what's best for the patient overall, and that will be different for different women. So that's why it's quite a nuanced answer. For some patients, it will definitely be that a frozen transfer is better. So if you are in some ways blessed with a high egg count and you've had a lot of eggs in an IVF cycle collected, remembering that one little follicle that surrounds the egg is like a little hormone making factory that actually can make enough hormones to sustain a pregnancy in itself, just one egg, one follicle. Imagine if you had 20 eggs collected, your hormones are raging. And we know that if we look at the endometrium from a sample in that context under a slide, it looks very different to a natural receptive endometrium. And the window of receptivity is much, much narrower in a stimulated IVF cycle than in a natural cycle for that reason. Women are often confused by the idea that, naturally so, that in a IVF cycle, we might freeze an embryo on day 6, but we would never transfer an embryo on day 6 of a stimulated cycle. Why is that? And how can that be? Or even day 7? Well, in a natural cycle, when you ovulate, because those hormones are running a lot lower amplitude, a lot lower kind of levels, the implantation window is actually different and it's much broader. So in nature, an embryo might only get to the cavity of the uterus to implant on day 6 or day 7, and it can still do that. But in the hormonal context of IVF, where everything's so zooped up, we know that the implantation window is much, much narrower. So even if an embryo is perfect and looks gorgeous on day 6, we would never put it back on day 6, we'd freeze it. And that's because the lining of the uterus is not receptive for the majority of women on day 6. So it's like, it's a difficult thing. So why wouldn't we do frozen transfers for everyone? Well, we get a lot of babies from fresh embryo transfers when we select the right patient. And, from the embryo's point of view, you've got to remember that being frozen and being warmed up again is in fact somewhat of a traumatic experience. So you can lose some cells. It certainly doesn't do anything to make the embryo better. It can only make the embryo worse and compromise the embryo by freezing it. Having said that, in a really good lab, freeze and warm rates are really, really excellent. And you've got to remember that an embryo is a ball of what we call pluripotent stem cells, meaning that it's got the capacity. It's amazing embryos, they're absolutely amazing. They've got the capacity to make every cell type in the body, and they're what we call undifferentiated, meaning they haven't yet gone on their different pathways in a significant way. And what that means is if an embryo loses a couple of cells to the process, it can rally and it can survive and it can divide and it can replace those cells. So an embryo, for that reason, is a pretty robust little thing. For a lot of embryos, being frozen and warmed won't compromise them in the long term. But, it's always better from an embryo's perspective to have not been put through that trauma of freeze and warm. So yeah, it's a balance.
So yeah, I guess talking with your specialist and seeing what works best for you and your partner is the best answer there.
Exactly.
Yeah. Okay, wonderful. I guess another question that's come up quite a bit as well is people who have a family history of endo or PCOS, or actually have endo, PCOS or adeno, should they look into freezing their eggs if they're in their 20s?
Look, it's a really good question, and I think all of those conditions are very different from each other. I would say PCOS is one of these conditions that women get really scared when they have PCOS, and they're scared because they're told they're going to be infertile. And that's not 100% the case. There's nothing wrong with your eggs if you have a polycystic ovary. There's something wrong with your hormonal environment and your balance. And, it's in some ways, polycystic ovaries is a blessing to egg freezing because you're someone who can get a whole lot of eggs in one go. I really think egg freezing is about thinking big picture about your fertility and where you're at in your life. And, definitely for endometriosis, which is a progressive condition that gets worse with time, and fertility can be compromised more and more by the progression of endometriosis and also the progressing age of a woman, because our eggs are at their best when we're younger. That's a very strong argument for egg freezing if having a baby is not in the imminent future, or if you want to have a family that's in over time, an extended family with multiple children, and you don't know when you're going to start having babies. It can also be something to do before a good kind of what we call clean out, or a surgery to optimize endometriosis related symptoms like pain, because again, it's a bit of, you're between a rock and a hard place, particularly with things like ovarian endometriomas, because you can't operate and remove the pathology without having some form of collateral injury to normal egg-bearing tissue of the ovary, and that's a problem. So I think egg freezing has a place in the holistic management of endometriosis to try and optimize the chances overall that a woman can have the family that she wants over her lifetime. At the end of the day, we can also consider embryo freezing for couples who are together and know they want to have babies together. So there's lots of options. With adenomyosis, the concern is more about the uterus. So, and adenomyosis is like a diffuse fibroid. So it's a process where the glands of the uterus grow into the muscle and cause changes in the anatomy of the uterus. So look, yes, egg freezing is something you can think about, but I wouldn't say it's directly related to adenomyosis. And I guess the more important thing is kind of thinking big picture about when you want to have a family, and thinking about egg freezing not as a insurance policy that you'll definitely be able to have a baby with the eggs you freeze, but more as creating a resource for yourself for the future that gives you extra chance of getting where you want to go, no matter what the future brings. And in terms of any kind of resource, eggs frozen at a younger age are always going to have a better pregnancy potential than eggs frozen later. And we know that when eggs are frozen and you're younger, the survival rate of those eggs is much better, because from a metabolic perspective, they're just a lot stronger. And again, the freezing process is a trauma to the egg, and we do lose more eggs frozen at an older age, even in the same lab with the same conditions, compared to eggs frozen at a younger age. And that's to do with the physical robustness of the egg. So like, for example, I remember when I was at school, I went to my 20-year reunion last year for my high school. I remember when I was at school, they used to make us do cross country, and I've never been the world's sportiest person, I have to tell you. And I remember feeling the pain of that cross country at the time. But if I had to do that now, I'm sure it would be worse.
Yeah.
So think of that like an egg. As we age, whatever the challenge is, the egg just doesn't have as good a kind of robustness to mount that challenge as it did at a younger age. And that's why when eggs do have to go through the cell divisions to make a baby, which is a very energy-rich process, they are more likely to make a mistake at an older age. And that's why we get more chromosome problems as women age.
Okay. So if someone was looking at freezing their eggs, so like would the 20s sort of be a more optimal time compared with 30s, or?
Yeah, look, from the eggs perspective, yes. So I think it's a more complex question again, in that you've got to think about egg freezing as something that is an amazing technology, but you also have to consider, as well as the health of the eggs that you put away, how likely you are to need them. Because it's an expensive technology and it's invasive. Our ovaries are inside of us, and it's invasive to go and get eggs from the ovary. And you also have to do about 2 weeks of injecting drugs and trying to get the eggs right before they're ready for an egg collection. So it is quite a difficult process and a costly process. So I always think, from the perspective of the egg, the younger the better. From the perspective of the egg, if it was just click your fingers and freeze your eggs, we should all do it when we're teenagers, but it's not. And so you kind of have to balance the burden of treatment and the likelihood that it will be a really good thing for you to have, versus the kind of, health of the egg at the time that you freeze it and the ovarian reserve. So the first thing to do, I think, I personally think, and this is just my personal opinion, that if you're in your mid-20s and you're thinking about these things, go have an AMH test, because that's the first important test to do to know, if your egg count is high, low, medium. That's completely genetic and out of our hands. And it doesn't mean that you're more fertile, less fertile. It just means that you have an ovary that has a certain density of eggs. And from a strategic point of view, it means you're a better or worse candidate for egg freezing. I always use the analogy of bra size, because I think women get that you can be a B cup or you can be a double D, and that's normal. It's not abnormal to be an A cup. It's not abnormal to be a C cup. We're all different, and that's just the way we are. So we can't change what we're born with, and we can't change our genes. So the ovary's like that. And so some women have a lower AMH, they can be perfectly fertile. Other women might have a higher AMH and they can be perfectly fertile. And if they're demographically otherwise identical, the AMH number means nothing, because in a natural cycle, you're only going to release one egg. Whether there were 20 runners up or 5 runners up doesn't matter. And the quality of that one egg is what's important in your chance of making a baby. So in terms of that, but knowing that in your mid-20s is actually quite powerful in terms of prediction, because if you're someone who is on that lower end of the spectrum, your ovaries aren't as big, you don't have as many eggs. We all know that we lose eggs as we get older, and whatever starting point we're at, we kind of continue along that trajectory, but it goes down as we get older. Then freezing eggs at a younger age is going to be much more cost effective for you. You're going to get a much better yield when you're younger than when you're older, and the quality of the eggs is going to be much better. But I personally think a sweet spot for freezing eggs is between 28 and 32. Now that would be, to me, the ideal time to freeze eggs for most people as a generalization, because the quality is still good, but by that age you kind of have an idea of when you might be starting your family. And if you're not going to be starting your family imminently, then at that age, eggs frozen will be a better resource for you for the future. So I have, in my time, frozen eggs for lots of women who are younger than that for various reasons. They might have bad endo, they might be about to undertake cancer treatment, sadly, and we might be freezing eggs for that reason. But I wouldn't say that there are huge numbers that I would routinely recommend to freeze eggs under the age of 25. I think it's probably premature.
Okay, that's a good answer. And again, something that you talk through with your specialist prior to making any decisions as well, because they know you and your treatment best as well. So another one that we've got here is there's an old wives' tale that apparently eating McDonald's chips after a transfer and pineapple throughout your cycle is apparently like linked to a better outcome. Is there any actual science to back this one up?
Well, look, I personally love Macca's chips, but unfortunately they're not very good for us. So we do know that actually trans fats, which is what is in Macca's chips, actually reduces your chance of pregnancy, both when it's ingested by the male and the female. So, I did actually a talk last night with Wendy Fideli, who's a beautiful nutritionist who works with me at my practice with my patients to kind of holistically manage diet and lifestyle to try and improve fertility. And she's got a particular interest in endometriosis as well, and anti-inflammatory diet. Fats from animals, trans fats, actually have a very high oxidative stress that they bring to the body. And so things like fats are not bad, fats are good, but we should be getting our fats from things like oily fish and olive oil and avocado and healthy, what we call monounsaturated fats. So I would say a definite old wives' tale, definite myth to bust on the Macca's chips situation. The pineapple is interesting. I mean, there's nothing wrong with pineapple. I can't think of a direct correlation as to why it might be. I know the pineapple has kind of been a symbol of fertility. The actually older reason for that is that it used to be thought to be potent for sperm. So it was more for the man. So I think that's kind of where the myth might have come from into modern culture. Yeah. But I have no problem with my patients eating as much pineapple as they want. And if they want to do it as a good luck charm, I have no problem with that at all.
Yeah. Pineapple over Macca's chips is probably the way to go.
Yeah.
So from that, I guess another question that we had was, what are some ways that you could naturally boost your fertility? So that sort of links in really nicely with what you were talking about with the chat you had last night.
Yeah. Yeah, so look, I think it's really important to consider whole person medicine. And, no condition stands alone. We're all people, and we all are a combination of our genes, our behavior, and our environment. So there are some things we can change and there are some things we can't. And the best thing I think to target is our environment and also our diet and lifestyle. So those are things that we can naturally try and get as good as they can be through conscious choices to try and optimize our chance of natural fertility. It's also really important to, if you are someone who can conceive naturally, not everyone can, but if you are someone who can conceive naturally, it's really important to be in tune with your body rhythms and to try and know when you're ovulating so you can just strategically time things right. And that will be in itself really, really beneficial. So things like getting to know the feeling of when you're ovulating and being more aware of that feeling. Some people are more aware than others, but sometimes I think it's just because we're really busy and we're not focused on our bodies. So sometimes, stepping back and just thinking and just being conscious and mindful of the feelings in our bodies gives us a better idea of when, an insight into when we're ovulating. So things like when your estrogen rises prior to an ovulation, remembering that estrogen rise doesn't mean you're ovulating. It's the body getting ready to ovulate and the body getting ready through the estrogen production from the follicle that surrounds the egg to thicken the lining of the uterus and to improve the fertility of the cervical mucus to make it more water-based and more permeable to sperm. But it also makes us more sexually interested. Estrogen is quite a happy hormone, so if we are conscious of our mood, you might notice actually as your estrogen rises that you feel happy, that you feel more sexually interested. You might have, more sensitivity to things like pheromones from your partner. And, so you just kind of have to step back from the hustle bustle and just concentrate on what's going on in your body. Mindfulness and meditation can sometimes help with that, just kind of shutting out other stimuli and just thinking about your body and how it's feeling, and just doing that on a daily basis for 5 minutes so that you notice these changes, because they're subtle, and if we don't pay attention, they're easy to miss. Things like fertile mucus is very variable person to person and cycle to cycle. So it's no surprise when you really think about it that every follicle, every egg that you release surrounded by its little hormone making factory is a little bit different. And every month, the level of your estrogen is going to be slightly different than the month before. And when you ovulate, it's going to be very slightly different from the month before, because we're not cookie cutters and we're not machines. You know, we're people and we're animals, you know. So in terms of that, things like apps can let women down, especially if their cycle's not, you know, clockwork, which actually rarely is a cycle clockwork. Because it's important to think about apps, how they work, in that they are just a computer. Most of them don't have any biofeedback. So they're just working out based on a maths probability, based on past experience, what future experience might be. So they don't really have insight into what's happening in your body. So I do have a few patients who, in terms of improving their chance of natural fertility, I've asked them to put away their app. It's actually useful to know retrospectively what their cycle was doing, but in terms of predicting ovulation, I'd be much more encouraging of getting kind of a bit more in tune with your body and not rely on algorithms. In terms of diet and lifestyle, diet's so complicated, and you know, every person is different. For endometriosis, it's really important to think about anti-inflammatory diets. That's actually really important for lots of different immune conditions as well. And, you know, certainly if anyone has a restrictive diet, for whatever reason, be it they might be gluten intolerant, dairy intolerant, they might have irritable bowel syndrome, they might be on a FODMAP diet, it's really important to really look at where you're getting your nutrients. And there's a whole list of really important things that we need to have in our bodies to optimize fertility. So I think anyone with a restrictive diet of any kind, especially even if they're just by choice, like vegetarian or vegan, you should go see a clinical dietitian if you're trying to conceive or if you're pregnant, because they'll be able to make sure you're getting everything you need in the right amount and also satisfying your body's needs and your needs to improve your fertility. It's also important not to forget the guy, because women, I think this is certainly in Western society, it's not necessarily everywhere, but women certainly carry the burden of fertility more than men do, in terms of the psychological burden, the physical burden, but also I think the just intellectual burden. People think, oh, it's a woman's problem, it's not a man's problem. That's not true at all. So it's important to remember that at least a third of couples who can't conceive naturally, the problem is solely and uniquely with the man, and the woman is fine. And in terms of 50% of couples who struggle, the problem is what we call compound, meaning that there's at least some male factor, even though it might not be the only problem. So just because you've got endometriosis doesn't mean your partner's sperm is fine. So, you know, I think when we have dietary interventions, it's really important to look at the male as well. Make sure their diet and environment is optimized as well, because if you do have a female problem, the better the sperm that the egg is presented with, the better the embryo that you're going to make. So I think that's a really important point with diet and lifestyle, is don't leave the man out in the cold. He needs to get involved, because optimizing the sperm will optimize the outcome.
So working on it from a team point of view and both doing it together. I like that one. So another one that we've had is, if you are doing the hormone injections through a cycle, some people who've done their first cycle, they're really freaked out the first time doing these injections. How do they know if they've done them like right?
So difficult question, because again, so individual, but I think it's all about education and practice. You know, most people who have IVF don't just have one treatment. It's the majority that will need multiple treatments to have a baby. I always say IVF is not a silver bullet. What we can do as a specialist is try and get the diagnosis right, target the treatment as best as it can be, work with the very best laboratory to try and give the best outcomes from the lab. But at the end of the day, the average baby born through IVF is the result of 2.6 stimulated cycles. And you know, it's pretty easy to realize that you can't have 0.6 of a stimulated cycle. So what that's saying is that most people who have a baby through IVF have 2 or 3 goes at stimulated cycles and transfer of the embryos resulting from those cycles before they take home a baby. So I always say IVF is a marathon, not a sprint for most people. And it's a technique to overcome infertility, but it's not a silver bullet. Some people's problems will be much more easily solved by IVF than others, and we're all different. So in terms of counselling success rates, it's very individual. In terms of the regimens chosen, it's also very individual. So it's not like there's just one recipe that you write and you just use it for every patient. That's not the case. But in terms of the injections and making sure you're doing it right, I always feel that it's really important for my patients to be super confident before they start a treatment. What we do at my clinic is my patients spend about an hour with one of my nurses before they start a treatment as an education session to teach them how to use all the medications. But then when they first instigate a treatment again, they come back for another education session, just to reiterate it. And we also have videos online to help. So, you know, I always say, if you have any questions at all or any uncertainty, do reach out for help. At the end of the day, for most things, not so much antagonists in an IVF cycle, which is stopping you from ovulating, but they're generally in a syringe that's pre-drawn up and it's pretty easy to see if you've given the dose. But in the pens, it can be a bit more difficult. If you stuffed up one dose, you know, I wouldn't encourage you to stuff up a dose, but if you stuffed up a dose, don't worry, it doesn't mean you've stuffed up a cycle. So I think if you think that might be the case, the best thing to do is get into contact with your specialist or one of the supportive team. It might be that nurses are available, your specialist might not be, you're on speed dial at that particular moment, but there's usually someone on call from IVF. I know at Melbourne IVF, we have our nurses there 6 days a week, and then we have a pager service on Sundays. So, you know, and I get those pages directly. So if there's an emergency, I still get contact. So there's going to be someone there who can answer your question or give you advice if you're not sure.
So yeah, reaching out just to make sure, you know, if there's any concerns or anything, you can get them seen to, and that way you're not left in the dark wondering.
That's it.
Yeah. And a lot of the questions we've also gotten is around supporting friends and family who might be going through IVF. So someone's also asked how can they support their friend and her husband who have unexplained infertility? What can they do to support them?
Yeah. So look, I think there's a lot of do's and don'ts, and obviously every personality is different, every relationship's different, how close you are to someone, how much they disclose to you. I think it's really important to cut people a bit of slack in terms of, you know, often when couples are going through treatment, all their friends are having babies as well, and they might be invited to birthday parties, they might be invited to baby showers. It might actually be really hard for those couples to go to those things, and, you know, just don't feel offended if they say no. You know, it's not because they don't care, it's not because they're jealous. It's just emotionally difficult and challenging to be confronted with those kind of things when you're trying so hard to have a baby and struggling. So I think just getting on their wavelength, understanding, not asking questions, not prying, remembering our, you know, emotional boundaries. Even if you've got a close friend, you know, you don't want to ask them, are you pregnant? Are you pregnant? When are you going to have a baby? You know, just think about it before you ask those questions, because you may not, even though you might feel very close to someone and you might love them very much, you might not be privy to their personal information, and they might be trying really hard to have a baby, and, you know, they might be struggling, and those questions might be really hurtful. So I think, you know, maybe ask the person how you can help, you know, and respect their boundaries. You know, what would you like me to do? Is there anything you wouldn't like me to do? You know, I'm here for you if you need me. If you ever need me, ask me. I'm here for you. You know, I don't want to ask too much. I don't want to say the wrong thing. You tell me how I can help you. I think just having an open and honest approach is probably the best and the best for the relationship, because, you know, then they know that you're there, they know that you care, they know that you want to help them, but they also know that you're going to respect their boundaries.
I like that advice. Definitely true. There's a lot of people out there that always get hassled by friends and family about when they're having babies, and it can be a very emotionally sensitive subject. So yeah, cutting slack and just giving that space is so important. Another question that we got as well is why only one embryo transfer? Why not two, especially if it's my 8th transfer? So I probably could have asked that when we were talking about transfers a little bit earlier.
That's a question that I would say is very individual. I'm not someone who never does double embryo transfers. So, I will do double embryo transfers sometimes. I think it's really important to understand in concept why single embryo transfer is considered best practice. And in many circumstances, it might be probably irresponsible to do more than one at a time. But there are other circumstances where it might be something that we do to improve the odds. So, look, basically, the more twins we make as IVF doctors, the more babies get admitted to intensive care with premature birth and associated problems. So I'm someone who has done a term, when I was doing my ONG training, before I got on the program, I did a bit of neonatal intensive care as a junior doctor, as a resident, and I can tell you it's a really hard place to be, where tiny little babies are born prematurely, go through really invasive procedures, might be there for months and months. It's a hard place for parents to be. We have advanced medicine, but we lose babies in intensive care all the time. And we also, unfortunately, have babies who survive who have severe disability because they were born preemie. So they might have hearing problems, visual problems, learning difficulties, cerebral palsy, lots of different concerns, breathing problems for the rest of their life because they were premature. So the main fetal reason or baby reason for not being a twin and not sharing a womb is that you're much more likely to be premature, and all the consequences of prematurity are potentially dangerous. So that's the reason that we don't want to make twins all the time, even though they're cute and a lot of twins do get to a reasonable gestation. But your chance of getting to a reasonable gestation if you're a twin, regardless of any other factor, is much, much worse than if you're a single baby. Not to say that single babies can't be born premature as well, they can. Twins also are much more likely to be delivered early for maternal reasons. So the fact that a woman's carrying twins might compromise her pregnancy. So for example, it's a big burden on a woman's body to be pregnant. We all, kind of accept that with open arms, but it's a burden. And what that means is you're much more likely to get gestational diabetes if you've got twins on board, because you've got 2 placentas, compromising your ability to metabolize things, especially sugar. You are much more likely to have preeclampsia, which might be a maternal reason for early delivery. You're more likely to have other complications like placental abruption, necessitating early delivery, or what we call IUGR, intrauterine growth restriction, meaning that the babies don't grow properly because you just don't have the resources to give 2 babies and your placenta's not as good. So look, all of these things are much more common in twin pregnancies. There are also maternal complications of twin pregnancies that are less serious but can be in the long term, problematic for women. So for example, you're much more likely to have pelvic instability or pelvic girdle pain and being immobile during pregnancy. You're much more likely to need a cesarean and not deliver normally when you're carrying twins compared to 1 baby at a time, which can have a whole heap of complications related to that. You're much more likely to have problems with prolapse of the uterus in old age and urinary incontinence when you have had a twin pregnancy. You're much more likely to have what we call venous insufficiency or varicosities of the veins in the pelvis and lower limbs after a twin pregnancy, which can cause lifelong problems. So there are maternal reasons why twins are not ideal, and there are fetal reasons why twins are not ideal. Having said that, there are also other ways that we can try and improve the chance of an embryo making it to be a baby. So, in terms of embryo selection, what we look at from the laboratory perspective is how can we choose the right embryo that's going to be a baby? How can we, from our perspective, reduce the burden of IVF treatment on a woman, reduce the time to pregnancy, reduce the number of treatments she needs to have a successful pregnancy? What I do in my practice is we use what's called morphokinetic analysis and artificial intelligence. I choose to work with Melbourne IVF, which is a brilliant lab. And in terms of, what equipment we have, we're blessed. It's a premium laboratory, not a low-cost laboratory, and we have all the bells and whistles, and that is a very lucky place to be. But in terms of, and I understand not everyone can afford that kind of treatment, But what I do in my practice is we use embryo selection techniques, looking at what's called morphokinetic analysis, looking at how the embryo is developing when it meets its milestones, and it gets what's called an IV score, or an artificial intelligence score, that helps us through machine learning understand which embryo is more likely to be a baby. That's a non-invasive technique. But then we also have at the moment, still more invasive techniques of genetic testing of embryos, and particularly in women aged over 35, where we know that a lot of embryos are going to make spontaneous errors related to the chromosomes, because that's what embryos do when women are over 35. And it's important to realize by the time a woman turns 40, 9 out of 10 embryos are going to be genetically abnormal and incapable of making a normal baby. So it's the majority, not the minority, in that circumstance. It's a real win if you can test those embryos and just rule out the ones that are not going to make a baby. And that's something that we can do to really shorten the time to conception and reduce the risk of things like miscarriages.
That's some really good advice and information that you just gave. Thank you. We also just had about, is the statistic still 1 in 8 couples that will experience infertility? Is that still current?
It's actually 1 in 6.
There you go.
So 1 in 6 couples, 1 in 8 women.
Okay, 1 in 8 women, 1 in 6 couples. Okay, well, yeah, that's a timely statistic, with it being National Infertility Awareness Week as well. So yeah, something that's not commonly talked about, but is, you know, so commonly occurring. Why do you think that is? Why is there still such a taboo around speaking about infertility?
I think there's a taboo about speaking about lots of things in women's health. I think it's partly because of discrimination, because, and I can talk from my own experience. I mean, stepping aside from the doctor role, before I was a fertility specialist, when I was trying to have my children, I'm blessed, I've got two boys. One's going to be 9, one's going to be 7. I always round them up. When I was trying for my children, I actually suffered infertility myself. And in the first 12 months that I was trying for my first baby, I had 2 miscarriages, and I was working full-time as a obstetrics and gynaecology trainee specialist. And there's no way I would have told anyone I was trying to have a baby, because, you know, it was almost looked like, and you'd think this is crazy in the specialty that I was training in, where we're delivering babies and looking after women in pregnancy, but it was almost looked at like you were letting the team down if you were trying to have a baby, and that, you know, you're compromising the, I guess, staffing of the hospital if you had an unexpected maternity leave. So there's no way I would have told anybody at that time, because I would have been concerned that I wouldn't have got the good surgical rotation with the good experience, you know, that someone would have, you know, kind of thought of me as, you know, not as integral a part of the team. I'm sure women experience that in every sector. You know, they don't want to tell their boss they're trying to have a baby, even if, you know, they're getting up at the crack of dawn to go and have a scan or a blood test and, you know, get to work on time. And it's so stressful, but they're just worried they're going to be discriminated against. So I think that's part of the secrecy. I also think there's taboo around both miscarriage and also termination of pregnancy. And I know that's a loaded issue and everyone feels different about it, but, you know, people don't want to tell anyone that they're pregnant until they know the baby's okay and normal. And they don't want to be judged if they decide to discontinue a pregnancy, if the baby has a problem. So I think that's also part of it. So one of the reasons we don't talk about fertility is the same reason that we don't talk about normal pregnancy until it's already almost halfway there, or, you know, kind of you're unable to hide it. In terms of other health problems, you know, infertility isn't that different in a way, in that, you know, health is private and confidential, and while, you know, some people might not feel comfortable talking about it, some people might think it's not anyone's business. So, you know, it's a complicated issue, because while women and men going through infertility do need a lot of support, and they're kind of shutting out their support network by not letting them in, at the same time, you can kind of understand why that is. So I don't have any answers really. I think the best thing, I think this kind of forum is wonderful, where, you know, couples can be, you know, able to be quasi-anonymous and ask the questions and realize they're not alone. I think that's wonderful. I do a podcast called Knocked Up, and I think that's a really great medium as well, because you can listen to a podcast in private, you can listen with headphones, no one knows what you're listening to, and you can get information through kind of veritable sources, answering questions and realizing support. And I think that's really, really good. I think people shouldn't also forget that professional support is available. So anyone who's suffering and they really don't feel that there's someone in their network that they can really talk to, consider that you might be able to go to see your GP and get a mental health care plan. Doesn't mean you've got a mental illness. It just means that you're needing some support. And you can go and see a clinical psychologist, and you can get 10 visits with Medicare rebates for some professional support. That can be really empowering, because they've got professional boundaries with confidentiality. They're not going to tell anyone anything. They may have had a lot of training, and they also may have supported countless couples in your circumstance or similar. So bringing that to the table and not forgetting that we do have a village, and we do have a professional village as well as a support village that we can call on, is really, really good.
Yeah, and there are specific psychologists that do deal with miscarriage or infertility or women's health related things as well, so they will really be experienced in helping those people as well. So that's a really good tool to make use of, for sure. I might open up just to see Ash or Alicia if you girls had any questions that you wanted answered as well.
I do, Ash here. It has been so great listening to you. But my question is, going with your gynaecology sort of experience, ovarian drilling, does that have any effects on ovarian reserves?
Yeah, it does. So basically, and that's a really good question. Thank you for asking it, because ovarian drilling is something that we used to do much more often than we do now. I wouldn't say I would never do that, but I very rarely do it. I mean, I could tell you less than once or twice a year would I do that. It's a technique where we are in many ways pathologizing the ovary when there's actually nothing too wrong with the ovary. There's something wrong with the holistic hormonal balance of the body. And you've got to remember, when you think about polycystic ovaries, that sounds like a real pathology when you say it like that, but they're not actually cysts, they're your eggs. And when we drill them, we're actually destroying your eggs. So things like ovarian reserve resection, ovarian reserve, ovarian wedge resection, or ovarian gulf balling or drilling is actually destroying your ovarian reserve. And it's doing that strategically to try and make the ovary less polycystic, but it's kind of, again, isolating the ovary without addressing the other aspects of polycystic ovarian syndrome. It's really important to remember that polycystic ovarian syndrome is what we call a diagnosis of exclusion, meaning that you have to have a whole heap of tests to make sure that that's what's going on, and that's why you're not ovulating regularly. And if you haven't had those tests, you can't actually clinch the diagnosis. So the first thing to do is to go and see someone who knows what they're talking about and get that diagnosis confirmed, because you can have a polycystic looking ovary and not have the syndrome. So, having a big healthy ovary with lots of eggs and a high AMH doesn't make or break polycystic ovarian syndrome. If I pulled, kind of 15 women aged 20 off the street and I did an ultrasound on them for no good reason, I would find a lot of polycystic looking ovaries, because when you're young, your ovary often does have lots and lots of follicles there and lots of eggs, and that's a reasonably good thing. It's in the context of other hormonal imbalances, be that the production of testosterone, be that the production of adrenal androgens, be that the point of our metabolism and the influence of sugar, be that our body weight. All of those things can influence our metabolic rate and our ovary and how our ovary interacts. So I would say that the reason that I don't do much ovarian drilling is that I'm not very into destroying eggs. I think it's good to have a good ovarian reserve. I think I'm much more into identifying the areas where we can change lifestyle, diet, and potentially use some medications if those measures alone are not successful, to try and get ovulation happening. I would say, bluntly, I've never met a woman I cannot make ovulate. If you failed ovulation induction, In terms of polycystic ovary, I mean, obviously if you're menopausal, you know, that would be a reason, or premature ovarian insufficiency, you probably can't ovulate. But if you've got polycystic ovaries and you've been told you've failed ovulation induction because you haven't ovulated on something like Clomid or something like letrozole, that doesn't mean you failed ovulation induction. That means ovulation induction has failed you, because you haven't actually been given a chance to release an egg. And, you know, treating that person holistically, you know, attacking from different angles, both lifestyle, sugar metabolism angles, and using different medications. And one of the benefits of being a CREI subspecialist is that, you know, I do feel really comfortable, you know, not following cookbook medicine and not, you know, just saying, oh, you've had 3 cycles of Clomid, that doesn't work at the highest dose, that's it, let's do IVF. So, you know, I would say seek out an opinion of an expert and they'll be able to help you ovulate. There are a group of women with polycystic ovarian syndrome where we do choose IVF primarily, and the reason for that is varied. One obvious reason is if there's a male factor of this blocked tubes or something as well, or endo as well as polycystic ovaries. There's another reason that IVF might be the right choice. There's also a group of women who ovaries are resistant to ovulation induction, and when you use follicle stimulating ovulation induction, they kind of do nothing, and then boom, over respond. And that threshold's so narrow that they're going to release 5 or 6 eggs that are otherwise healthy, and you're not going to let them go home and have sex because you have a really high risk of high order multiple pregnancies like triplets and beyond. So that is a group of women who I would sometimes use IVF primarily, principally to control the risk of multiple pregnancy. But you'll be able to get every woman to ovulate with a polycystic ovary if you use injectable follicle stimulating hormone. The difficulty and the art is getting it right and making sure there's not too many eggs that release in the one go. So I'd much prefer that over ovarian drilling.
Does that answer your question, Ash?
Yes, that sure does. Thank you.
Alicia, did you have anything that you wanted to ask or anything? If not, that's fine. Okay, cool. I think the last sort of thing that we had really is just advice for people who are just starting out, realizing that they are struggling, falling pregnant with their partner. What sort of steps you'd recommend them go on first, like where they should sort of start?
Yeah, so I think the first port of call should be go and see your GP and have a chat about it. The most important thing, I think, is knowing what's normal so you can know what's not normal. It is really normal that it can take a few months to get pregnant, but 80% of couples where there's no problem are going to conceive within 6 months. So if you've been trying for 6 months and you're over 35, and that's because older women have other problems relating to egg quality, I would go and see your GP and just get the basic test done, and make sure your partner gets the basic test done too, because a lot of the time it's a male factor. I can't tell you how many times women have, you know, kind of gone to all kinds of people to help them. You know, there's lots of knowledgeable people in our community, naturopaths, Chinese herbalists, doctors. They've had every test under the sun, and then 2 years later their husband or partner does a semen analysis and you realize where the problem is. So don't assume it's you. If you're having trouble, investigate as a couple. If you're younger and you've been trying for 6 months, you know, it's reasonable to try for another 6 months if you want to before seeking help, but it's also reasonable to seek help if you want to. So I would say leave it to your level of anxiety and also your level of intuition, because sometimes we know when there's a problem and we just feel it in our waters and we just have a gut instinct. And which, if that's the case, go and seek help. I would also say seek help immediately if you're not ovulating. So if you don't have a regular menstrual cycle, you're not getting a period every month, that's a pretty surefire sign that you're not releasing an egg. Or if you do release an egg, it's random and you have no idea when that's happening. So you really don't have the power to time sex at the right time. And the egg is like a shooting star. The sperm can stick around for about 5 days in the woman's body. And that's really why as a species we survive, because the egg can only be fertilized for 24 hours. So if you don't have sex at the right time and that egg is released and there's no sperm, there's no way you're going to get pregnant. So that's really, really important. Yeah, so I would say seek help at the earliest time that you are feeling stressed about fertility, and go and see your GP. They'll do some tests at an early stage. And if those tests show that you need to be referred to a fertility specialist, they'll be able to give you a referral letter, which means you can access Medicare.
Okay, lovely. That's a good place to start. And yeah, the investigating as a couple again, not just popping it all onto the woman. So good point. I think that's all that we have. And Alicia's just said, oh, thank you. She's appreciated listening. So that's great. So yeah, is there anything else that you sort of wanted to share with us or wanted to talk about this morning, Raelia?
Look, just not particularly. I'd say we're always looking for people to listen to our podcast Knocked Up. So if you ever want to jump on, it's free. It's on all the channels like iTunes and Spotify and anywhere you listen to podcasts. So jump on and join us. And if you have any friends or family members that you think might benefit from listening to our podcast, share a link and leave us a rate and review. And in terms of any questions for me, I can be reached on my Instagram at Dr. Raelia Lew. Feel free to DM me if you're listening to this after the time, and I'm happy to respond.
Wonderful. Thank you so much for that. And we'll share a little link to your podcast on our socials as well. You're welcome. No, and thank you so much for joining us this morning and answering those questions. We've really enjoyed having you. Thank you.
My greatest pleasure.